Hello and welcome to Middlebury 5-0. I'm your host, Officer Chris Mason, and with me in the studio today is Sherry Greifzu. Welcome to the show, Sherry.
Thank you.
And you are the Executive Director of...
I'm the Interim Executive Director as well as the Clinical Director at Addison County Home Health and Hospice.
Well, your title is even longer than I knew. I feel like the longer your title is, the more important you are.
I'm not quite sure about that.
No. But it sounds impressive.
It's very nice. I have the privilege of being able to work with a great bunch of people, taking care of patients in their home. And with the leadership team and the clinical staff, we develop and guide the work so that the patients get the best care they possibly can and have the best quality of life at home.
Sure. So we're going to talk about advanced directives today. That's going to be the main kind of thrust, I think, of the show. But I think it would be helpful if you talk just a little bit about home health and hospice and just in general terms about what the organization does, what it's dedicated to.
Okay. The Addison County Home Health and Hospice is what's described as a post-acute care healthcare setting. So we take care of patients in their home. We take care of quite a few patients. I'd like to share some statistics with you, if that's okay.
Absolutely.
It was started in 1968.
Okay.
And to date, we have about 155 employees. We take care of patients from birth to death. So we have a mother, infant, child program. We provide skilled nursing services, therapy services like physical therapy and occupational health therapy. We also provide hospice and palliative care for end of life, symptom management, plus medical and nursing care. We provide free foot clinics, flu clinics.
Foot clinics, did you say?
Foot clinics, yes.
What's a foot clinic?
Well, I'll tell you, if you think about it, when you have elderly patients, they might not be able to care for their feet. They might have medical conditions like diabetes, and they might have circulatory problems. So walking could be very traumatic for them. If their shoes don't fit because their toenails are too long, they could get ulcers and they can have pain in their feet. And so that their quality of life and their health could be impacted.
Right. I'm finding it harder and harder to reach my feet.
So
every day it seems like more of a struggle.
So we go to some of the senior homes, some of the residences, areas where we might have a Meals on Wheels luncheon for the patients or clients, and we have nurses and aides to take care of people's feet. So they get their feet soaked or washed. It depends on their medical condition. They get their toenails cut. We look at their skin if they need to see someone, if they have to see their medical provider. We do that as well. We tell them to do that. But it's a very nice service. Patients love it. They wait for it, and they get angry if we have to cancel it for bad weather. So we provide foot clinics, flu clinics. We have a telehealth program that we provide, a scale, blood pressure cuff, and then a machine that measures how well their lungs are performing, so that the patient can monitor themselves. We call them every day, every other day to make sure that they're okay, give them some tips, nursing care over the phone to keep them in the home and keep them safe so that they don't have to go to the emergency room in the hospital or go back to their physician's office. And then we also provide an unusual program that the state supports through Medicaid. It's called a Medicaid waiver program, where we provide case management for patients, and we send in personal care staff to take care of their physical care and help them take a bath. We also provide homemakers to help clean their house and do their dishes or make their meals for them so that they can stay in their home. The goal for healthcare today, nationally and all over the world, is to really promote wellness, keep patients in the home as long as they can, and keep them out of the acute care hospital. So we do all of that in the home care setting.
That seems like such a different direction to the one that I associate with the healthcare industry. Is allowing people to be in their homes, allowing them to maintain those connections with the people around them, and be in that familiar environment as well.
Yes, it's really nice.
And still get the care that they need to live the lives that they want to live.
We have these patients have many specific diagnoses. For instance, they have congestive heart failure that's stable, that they can stay in the home, but they have to need a skilled service in order to receive our services.
Right.
They might have chronic obstructive pulmonary disease. Many of these patients have smoked, so that they might, or they've worked in the mines when they were younger, or in the fields and they've inhaled any of the chemicals they use on the farm.
Sure.
They might have had orthopedic surgeries from injuries, falls, aging, where they have hips and knee replacements. I know that. We take care of patients with infections. They might need IV therapy, from chemotherapy to antibiotic therapy. We manage that. And of course, our hospice and palliative care program, a very high percentage of those patients have cancer, so our patients have cancer as well. And then if they have any kind of gastrointestinal problems, and they maybe have wounds or they've had surgery. So you name it, we take care of it if we're able to. If they are too sick, they need to be in a hospital or in a rehab center, but when they're able to go home with skilled services, that's where we step in and take care of them and help them on their course to get better and stay in the home.
Right. So if those services weren't available, they would have to be driving to the hospital, to those care facilities.
Correct.
And getting those services in that clinical environment.
That's true. And home health care is much less expensive when you think of how much we spend on health care in this in the United States. Home health care is much less expensive than a nursing home visit or even a hospital 3-day stay or even emergency visit.
Right.
It's much more efficient, and it makes the patients and the families feel really good about their life when they're trying to manage it themselves.
Sure.
Helps them take control of it.
Yeah, the psychological benefits have got to
Right.
be enormous. Yeah, I think about what I would prefer myself, and being in my house,
Right.
surrounded by familiar things, in that comfortable environment, as opposed to going to a hospital. I mean, there's no choice there, really.
Right. And one of the questions on the form that we're going to be talking about says, when you're at the end of life, where do you want to be?
Right.
And many of our patients choose, I want to be home with my family.
Sure, of course, of course. So, advanced directive, could you just talk a little bit about what that is before we get into the details, the nitty-gritty of it? Just in most general terms, what it
an advance directive is a piece of paper. It's a document that will describe a patient's wishes and also leave care instructions in the event the patient cannot make a choice for themselves, whether they're confused, they're unconscious or whatever, or they don't have really good decision-making mental capacity.
Sure.
And it's really in the event that they don't want to or they cannot. And the Vermont law gives the patient the right to decide what they want, either in end of life when that situation occurs.
Okay.
The nice thing about an advance directive is it lessens the burden and the strain of the family member or the advocate or the agent or family significant other. Those people that will be making decisions will have a nice guide, knowing that if they have to make a tough choice for the patient for health care, they've got some guidance and they feel good about what they're doing, that in their heart they know that they're making a good decision for their loved one or their friend.
Sure.
And that's really what it's about.
Because being in that position, being in that situation anyway, where somebody that you really care about is experiencing a crisis and possibly sort of moving towards death, I mean, that's so emotionally challenging to be there anyway, and then to have to make those decisions at the same time without any guidance,
Right.
is just so difficult and so confusing as well, especially if there's disagreement. And
Yes, really good point. So the beauty of having your personal wishes on a paper, on this piece of paper, is that at least it clears up so that there aren't any disagreements among family members or whatever. But it also gives confidence to those that are making that choice, especially when they're really tough, whether to, quote, pull the plug, take someone off a ventilator, stop antibiotic therapy, stop a medication that's going to keep a blood pressure up enough so that it won't drop and they don't have a problem. And it also helps the patient's physician to make good choices as well. A lot of patients, elderly patients, oh, I'm not going to bother, I'm going to let my physician decide. But then the physician will have to go to the loved one, the caregivers, those that have an interest in the patient, and sometimes they may not all agree on what the plan is.
For sure.
And so the patient may say to you, I want this. And they may say to me, but you know what, I told him what I wanted, but I really want this. So that I might bring to the table what they told me in secret, and then you're saying, oh, that's not true, he told me this. So this really helps support it's the advocate for the patient on their personal wishes.
Sure, yeah, absolutely.
So I was excited to do this because I filled out mine too.
Well, I was going to say that there's a tremendous amount of reluctance to face up to these issues, to grapple with these issues. I think in our culture especially, there's a really powerful desire not to talk about death, and not even to think about death, to kind of push it aside, and it seems like a tremendously unhealthy facet of our culture, but it's a barrier, and I could imagine many people putting this off just because the idea of facing up to those issues of mortality,
that's right,
is just too difficult, it's just too challenging for them, and they really just don't want to. They don't.
I'll use the example of my father.
Sure.
Retired serviceman in the Army, 21 years. He always said, hard worker, great work ethic, wonderful father. He always said that when he dies, he just wants to drop. He doesn't want anybody to make a choice about him. And I said, but Dad, it doesn't happen that way. Usually, you get sick, something happens, you got to make tough choices, and it's good for you to tell us what you want. Even if you don't want to fill out the paperwork, please tell us what you really want. We don't want to do anything that isn't your wishes. And then he said, well, I don't want to be kept alive on a machine if I'm going to die. I don't want to go through chemotherapy again. He had lung cancer.
Sure.
I thought I was going to die through that therapy, but this was before all the great medications came about in the early 90s. I don't want to suffer. I don't want to have a lot of pain. I don't want to be able to not be the man that I was, because he was he was the person to everybody, the man for everyone, was always there if you needed him. So he survived lung cancer for 5 years, and he did not want to write. He had a will. I was the executor of his will. We knew where the money was going to go when we sold the house and to take care of my mother. And he said he wanted to die first. He didn't want my mother to die first, but he wanted all these things. But he did not want to put it on the paper. So
that makes it more real. Somehow,
it makes it more real. And then he realized, oh my God, I'm not going to live forever. And he was only, when we talked about all of this, he was only 62 when he got his lung cancer. But he survived 5 years. He beat the odds. They said he was going to die in a year, and he didn't. He got a clean bill of health. And I remember on a Sunday, he was helping me put a patio in, because I was the boy he never had. We did all these things, build houses and everything, right? And I said, Dad, I said, you know, you beat lung cancer. You just had your clean bill of health. Want to just validate everything's good. You still want me to, you know, if anything happens to you, you still want me to make those choices for you. And he says, yes, I still uphold that, but don't worry, honey, I'm going to be fine. And I said, but how about losing a little bit of weight with me, because you're getting really heavy, because now that you feel good, and I wouldn't want you to have a heart problem. Wouldn't you know? Thursday, he comes home from work. He was retired, but he comes home. He had a part-time job, was watching Wheel of Fortune, and just went out. His heart stopped. He had to be put on a ventilator. And went to the hospital. He never woke up. And during that time, I was trying to figure out with my family, because they didn't want to make that decision, how soon do we pull the plug? And he always said, don't keep me going. I don't want to be a vegetable. And there's a fine balance of, if you pull it too soon, would he have had a chance? And if you pull it too late, is he going to be in a nursing home where he doesn't know who he is, and he'll be in a state where he would have total physical care?
Sure.
So we made the choice based on he didn't have a paper, but we all got together, we knew what he wanted, and we made a good choice. We we pulled the plug on a Thursday, and he died at hospice on Sunday.
Right.
So, but he told me everything that was in here, but wouldn't write it down.
Sure.
Yeah. So I wrote mine down yesterday in preparation for this today.
Well, let's look at the form a little bit.
Okay.
So this is something that you sent to me.
Out. Yes.
Yep. And it has one of these inside it. So this is a document that can be used as an advance directive, but you don't have to use this document. You can.
Correct. We actually have two.
Okay.
The blue one is it's a very easy to read one, and the beauty about this one is it's user-friendly, not a lot of questions, it gets to the point,
Sure.
and it's valid in Vermont.
Right.
But it's only valid in 42 states, not all 50.
Okay. So let me just hold that up just so they can.
Yeah.
So they
It's
can see
called
that.
5 Wishes. And the 5 wishes is they want the person I want to make, it's identified who the person is that they want to make healthcare decisions for them in the event that they can't. It defines the kind of medical treatment they want or they don't want, whether it's aggressive or pull back and it's supportive. They describe how comfortable they want to be when they're toward their end of life, who they want to treat them, and the information they want their loved ones to know. So it's a very personal advance directive.
And I was reading through it, and it has some other things as well. It talks about there's a spiritual dimension to it,
Yes, there is.
there's even sections which go into what you want the environment to be like as you're going through that process. It was way more involved than I anticipated from a document.
Right.
So it talks about music
The
being
music,
played, poetry being read
that's
to
right.
you.
If you want to be in your bed with your people holding if your friends or your family holding your hand, what do you want to have around you? That kind of environment, besides what kind of care you want to receive.
Sure.
Pain medication, fluids, all of that, tube feeding, all of that is in there as well.
Absolutely.
It's very specific, but it's yet, it talks about things that sometimes people don't think about. And even in this one, the Vermont Advance Directive that came out of that folder, it talks about, do you want to be cremated? Do you want to have a regular funeral? Do you want to be buried in a cemetery? What kind of music do you want? And you could write in what you want to wear, what you want them to dress you in, and that kind of thing. Right. And it's funny because I remember spending a lot of time thinking about the music and the writings that we did for my father. That I did not put it in my own because I would need to put more thought into it.
Sure.
Whereas here it brings up those questions that people don't think about in a time of stress, as well as it gives somebody time to think about it, and then when they're ready they can even say goodbye and let go instead of having to do something very quickly. Right. So with sound mind, I'm making a good decision about my end of life, and I want people to be comfortable because it's my wishes and not put a burden on them.
For sure. Yeah. And again, when people are in that situation, when they're with that person that they love, it's such an emotionally challenging situation to be in that, sitting calmly now, they may know, oh yeah, of course, if the person I loved was in this situation, I would want to make their environment as comfortable and as meaningful as it possibly could be. I would want to be reading to them their favorite poems or their passages from scripture or whatever it might be, whatever is significant to them. But when you're in that situation, your mind is so often just, it's capsizing, everything is eclipsed. So to have that document, to have it laid out, to have that there that you can rely upon, and it might be so important.
Yes, it is, and it also supports the fact that if people can afford it, they can prepay for their funeral. So they can really think about it as well. And there are a lot of, my mom actually prepaid for hers. My aunts, we didn't for my father. We bought the stone so that they could put their both names on it, but my mother didn't want to put her name on it because she thought it was a bad omen. But at least everything's there ready to go. So this is all part of what do you do and how do you do it. Because think about it. When you're there, and so it's my dad, you have, one day, 24 hours to think about, what do you want for the music? What do you want for the sayings? Who do you want to have come to the funeral?
Absolutely.
What should you do? Did we do everything that he really wanted? Because you want to make sure it's perfect.
Right.
So
Yeah,
you're
and
right.
you're always, and you're second guessing yourself.
That's right.
Yeah.
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 I actually fired the minister and got somebody else because he was trying to tell us that he wanted to do the funeral for my father the way he wanted to, and I said, oh no, it's going to be the way we want to. This person's going to read this person's going to read this, we're going to read this saying out of the Bible and whatever. And my mom was saying, oh, I'm so glad you fired him, because we didn't have the nerve. You know?
I think a lot of people wouldn't have that strength, and particularly under those circumstances, they might, even if they would normally, they might not. You know, when they're feeling so frail, so vulnerable. So I think it's good. So I think a lot, hearing about your mother, prepaying for her own funeral, I think to a lot of people that would probably sound really morbid. Like the idea of that, it would be like, whoa. but I think it's another one of those things where we are all going to die. We're mortal creatures, and we have to be able to look at that. We have to be able to face up to that, and we have choices now that can really make a difference on how that process goes. And not facing up to it makes it much more likely that it's going to be a very, very negative experience. I mean, it's probably going to be a negative experience anyway for the people around, but.
I have to tell you about my uncle was the policeman. So he was the kind of person, he was married twice, no children, always loved his oldest sister, who's my mother, and always came up to Vermont and Connecticut to see the family. And I always said, Uncle Bill, we've got to do this. I mean, he liked to drink, he liked to smoke, he liked the women, he liked the party. And I said, you have to help me figure out what's going to happen. I'm the executor of your will. I've got to do all these things. I want an advance directive. Oh, Sherry, don't worry about it. Everything's going to be fine. When I die, it doesn't matter. You'll just take care of it. I said, Uncle Bill, you have no idea how hard this is going to be. And the people at work can vouch. He was very, very sick last year in November. He got very ill, had to go in the hospital. I had to fly out to California twice, had to arrange everything. There was a lot of other issues with with friends that were taking advantage of him and stealing money. And then I was on the phone every day with doctors out there on, he had kidney failure, he had lung failure, he had liver failure. He had so many problems. He didn't have cancer. Had no life insurance. If he had cancer, he had life insurance. That was a stipulation. He thought he was going to die of cancer, and it didn't happen that way. And I was the durable power of attorney for him to make I was the healthcare proxy. He didn't have the advance directive, but he always told me, do the best you can. I'm a free spirit. I don't want to suffer. I trust you with everything. And he was lucky because I'm a nurse. So that each step of the way, when the doctors wanted to give up, I said, but wait a minute, you just started treating him. If we did this, what are the chances of him getting better? Antibiotic therapy, kidney dialysis, all of those things. Is he out of the woods yet? Could this be an acute situation? Could we hold off a little longer and see? Let's take it in stages without writing him off right away. So we were able to, and he always said he wanted to die with his family. And if he died in California, he would not be with anybody but me. So we were able to sell his house, take the proceeds, fly him on a medical plane, send him to Yale. And in 2 weeks, we worked on him to try and save his life. But we knew at each day, if this didn't work, we knew we were closer to unplugging him from the ventilator, stopping dialysis, stopping the antibiotics and the medications to keep his blood pressure up. And to the very end, I kept asking him, do you trust me? And he said, yes. And then I said, you tell me when you're ready to give up. He told me. We stopped everything on Friday, and he died at 5 o'clock on that Friday. It was great. He knew what he wanted, but he didn't write it in paper, but he told me. And I was able to do it.
Well, I've seen kind of both sides. As a police officer, I've seen people being brought into the hospital, and I've seen what emergency resuscitation can look like. I've seen it with the tubes drilling into people's bones. It's messy. And sometimes that's necessary. That's what you want to happen when that person has a chance of life. You know, those procedures can be really, really significant, but there's a grimness to that. And I know for myself, you know, I wouldn't want to be going through that if there was not a really good reason for me being subjected to that. And I've seen death. My grandmother died when I was a lot younger, but she died in her home. She was surrounded by her family. Her daughters, her sons were there, her grandchildren were there. I was there. I was lying on the bed next to her as she died. She slipped away. And yes, there was grief. And I remember my mother screaming, wailing when my grandmother died. But there was a beauty and a dignity to that process as well. And I can't, as difficult as it was, I can't imagine it being any better than it was under those circumstances. So having seen those contrasts, it makes sense. And this, you know, reading through this form, looking at this form, this is about choices. This is about making informed choices. So it's not just a form that says, you know, you have to take me off of a ventilator. There are options there for keep me on life support if that's what you want. So it's not advocating one very specific path. It's saying here are your options. Here is the range of things, and you have the opportunity now to make a choice.
One of the things that I would recommend is that also to involve your healthcare provider to help you make those choices. Being a nurse, to me, it's simple in the fact that it does give you choices. You're right. Do you absolutely do not want to be on a ventilator? Or do you want to be on a ventilator in the event that there could be hope that you could get better? Or, I can't remember what the other one was, but I picked the middle one only if there was going to be hope that I would survive that traumatic event, like you talk about being a police officer and bringing people into the emergency room and cracking chests and all these tubes and all those other things. You know, first and foremost, you want to try and save a life, but many times you can't based on the length of time the patient has been sick and the medical condition. So being able to put that in balance and understanding all that and helping the patient understand some of those choices that they're making.
All right. Well, thank you so much for coming in.
Oh, you're
Sherry.
quite welcome. And you know, if you're interested in coming to the agency and seeing what we do on the inside or whatever, please feel free to call, and we'd love to have you.
And I will be filling out my advance directives.
Okay.
Just as you did.
And if you need a co-signature to verify that you're of sound mind, that you filled this out, I would be happy to do that for you. I had 2 people from work co-sign it for me yesterday.
Thank you so much.
Thank you very much.
So until next time, drive safe, and may all your mischief be of the lawful persuasion.